formal and interactive. I know that you guys will have a lot of questions to ask. So our instructors from the overseas will try their level best to answer your questions and help providing any sort of equipments that you may need. Okay, so we'll start by asking Madhavi to do her first presentation. Over to you, Madhavi.
Thank you. Let me see if this works. I'm just going to share my screen. Can you see the screen?
Yes.
Excellent. Okay. So I know most of you. So my name is Madhavi. I'm one of the neonatal consultants at Bristol in the UK. And thanks, Anil, for organizing this and volunteering me for this presentation. Okay. So let's see if this, okay. So essentially, I thought we'd start off with a little bit of look at the new algorithm and then summarize the key changes that have taken place and dividing it into the initial assessment, the ABCD approach, and also a little bit about when to stop resuscitation. So this is what the new algorithm looks like. It's a bit more colorful than the old one, but you will be pleased to know the actual approach hasn't changed much. So it's still assess, keep the baby warm, ABC, so airway, breathing, circulation, and occasionally needing drugs. And there's a bit more information about how to manage preterm babies as well. So if you break it down, so you're drawing and covering the baby, assessing the situation. So we're looking at color, tone, breathing, and heart rate. And while you're doing that, you're also thinking of, do you need help? One of the things that's been introduced as a new thing in as a more emphasis in the new algorithm is considering optimum umbilical cord management. So delayed cord clamping where possible to make the transition a bit more smooth for the baby. And once you've done all of that, you go on to managing the airway, then breathing, which is inflation breaths, and then ventilation breaths, and then moving on to circulation, which is chest compressions and or drugs as needed. Okay, so let's look at it in a structured manner. So in terms of initial assessment, the key changes have been a bit more emphasis on thermoregulation. As you guys know, babies can get cold very quickly in the outside environment because they're wet and they have a larger surface area for the head and they can lose temperature very quickly. And we know that with every degree that your temperature falls below 36.5, the mortality goes up by nearly 28%. So it's really, really important to make sure the baby stays nice and warm through the resuscitation. So still dry, wrap, keep the baby warm, whether that's with an overhead heater or with a plastic bag for preterm babies. The other thing is looking at optimal cord management. So that's looking at delayed cord clamping. So the recommended is for at least 60 seconds, so for a minute. And it means that you can do the initial assessment. So you're drawing and wrapping, assessing, putting the head in the neutral position, and all of that can be done while the baby is still attached to the cord. If the baby needs inflation breaths, then that's your time. And if it's not possible to resuscitate with the intact cord, then that's the time to think about clamping and cutting the cord and moving the baby to the resuscitator. If the baby is over 28 weeks, you can, and DCC is not possible, then you can potentially think about cord milking as well, just to provide the baby with a little bit more blood. For babies less than 28 weeks, we stick with delayed cord clamping only. Okay, and I will talk about that, the reasons why in a minute. So as we know, at birth, babies are small, they're wet, and they are attached to the placenta, and their airways are still full of fluid. So this is a point where the baby is taking a breath, opening up their lungs, and transitioning from a fetal to a baby sort of circulation. When we do immediate cord clamping, so as soon as the baby is born, if you're clamping the cord, taking the baby away, what's happening? So this baby suddenly got an immediate loss of venous return from the placenta because we've cut that supply off. And also because of that, you've got a drop in cardiac output and also a drop in the systemic resistance, and the blood pressure goes up. So you have an increase in systemic resistance Okay, so you have a boost up in their blood pressure, they have a drop in their cardiac output, and they have a drop in their heart rate till their lungs start reopening. For a vast majority of babies, they kind of get on with it. But for those babies that are already in trouble, which have been compromised for whatever reason, or the babies or preterm babies, for that example, this might make it a bit more difficult for them to transition smoothly. Okay, so this was a publication from 2010, and if you look at the time from birth as the breathing's established and look at the heart rate, as soon as the cord's clamped, you can see the heart rate drops, and then it takes a little while for the heart rate to come back up. Okay, so this is with immediate cord clamping. When you delay the cord clamping and let the cord pulsate for a bit longer and let the baby inflate their lungs and transition while they're still stuck to the connected to the placenta, you're allowing that placental blood to contribute to the blood volume. John was just mentioning about how, particularly in the developing world, we've got an increase of iron deficiency anemia as well. And allowing that little bit of extra placental blood transfusion does help to reduce the need for blood transfusions, reduces the risk of anemia of prematurity as well for babies. And this is also particularly important for preterm babies. It is also allowing a more gradual increase in systemic resistance. So the baby is transitioning nicely and gradually. So you have a smooth cardiovascular transition to extra uterine life, and you have a transfer of blood volume from the placenta to the baby. And all of this means that you have less frequent bradycardias. So if you compare this to the previous slide I showed you, with delayed cord clamping, you have a much smoother heart rate, and there's some good papers by Professor Stuart Hooper and his team from Australia, which looked at lab studies of cardiac output and in animals, and it's almost identical to this. So the cardiac output does the same thing as well. So you have a much smoother transition. Okay. So where did this whole thing about immediate cord clamping come from? So once upon a time, we used to leave the baby connected to the cord till the cord stopped pulsating and then clamp the cord. A few years ago, there was a Cochrane review mainly looking at reducing postpartum hemorrhages in women and actively managing third stage labor. And part of that was clamp the cord, take the baby away, and then give the mom some syntocinon and deliver the placenta in a controlled manner. Not a lot of thought was given to what was going on with the baby in this study. And although it didn't particularly mention about the timing of clamping the cord, it kind of snuck back into practice. And over the years, we've had more studies as we've understood more about neonatal physiology and transition. We've been trying to reintroduce optimal cord management and delayed cord clamping. Another practice which we sometimes see is umbilical cord milking. This is so that you get a little bit more blood from the umbilical cord into the baby. In terms of evidence for this, delayed cord clamping for at least 60 seconds is the preferred option, basically because it's much more smoother transfer of blood to the baby. And for babies over 28 weeks, if delayed cord clamping is not possible, then you can consider cord milking. However, for babies less than 28 weeks, do not undertake cord milking. And the reason for this is when they looked at evidence and compared cord milking versus delayed cord clamping, this was the PREMOD study where the study was actually halted before they were a third of the way in, because for babies 23 to 27 weeks, there was a significant increase in severe intraventricular hemorrhages with cord milking in the cord milking group. Okay, as you can see here. So although there wasn't a huge difference, statistically significant difference in deaths, certainly with severe IVHs, so grade 3 and grade 4 IVHs were much higher in the cord milking group. So it is not recommended for babies less than 28 weeks. Happy with that? So, and certainly in our practice, we found that as we've gotten better at transitioning babies and delayed cord clamping in preterm babies, we found that our babies are a bit more stable in the first few days, particularly, And we've had fewer IVHs as well. So yeah. So in summary, so for initial assessment, dry, wrap, assess, and put the head in the neutral position, and do all of this while the baby is still attached to the cord where possible. And if inflation breaths are needed and you can't do that while the baby is still attached to the placenta, then clamp and cut the cord. For babies over 28 weeks, if this is not possible, you can potentially think about cord milking. Okay, right, moving on. So you've got a baby that does need some intervention, is not breathing on its own. So you've clamped and cut the cord, got the baby out, still keeping them nice and warm. You move on to airway. The good news is the initial management of airway is exactly the same as it was before. So you still put the baby's head in the neutral position, you choose your appropriate size mask, and then you check your bag valve masks TP's pressures, make sure that they're working. And in terms of TP pressures, for term babies, it's still 30 centimeters as your starting pressure. And for preterm babies, you start at 25. You ensure that there's a good seal around the nose and mouth, and then you give 5 inflation breaths. And you're looking for chest movement. So do not move away from inflation breaths till you actually see chest movement, okay? And you've aerated those lungs. So what happens if your chest does not move with your inflation breaths? I'll get to that in a minute. The other things to think about is air versus oxygen for resuscitation. Once upon a time, we used to resuscitate everybody in 100% oxygen, and then we decided that was a bad thing. So we veered to resuscitating everybody in air. Over the last few years, there's been a newer evidence coming mainly from Japan, actually, in some of the studies they've done with preterm babies, and they realized that the extreme preterm babies, particularly less than 28 weeks, seem to transition a little bit better if you started resuscitation in about 30% oxygen. So this is a change in guidance from the previous 2016 guidelines. So for babies over 32 weeks, we still start in air. So for term babies and babies over 32 weeks, babies under 28 weeks start in 30% oxygen. For the ones in between, there's not a huge amount of evidence to suggest either way. So you can start in either air and titrate up, or start in 30%. Right. The other questions we usually get is about meconium. Babies where there's thick meconium at delivery, what do we do? If they come out screaming, that's absolutely fine. They've got a patent airway, just dry wrap them, give them to their mom. If they are not breathing, then you start with the standard NLS algorithm. So you still do a neutral position, inflation breaths, reposition, repeat inflation breaths. If there is no chest movement despite 2 sets of inflation breaths, that point, inspect and suction under direct vision. The reason this has been clarified is because quite a lot of the time when you've got meconium around, the reason the baby is not breathing is because they're floppy and they've got their tongue flopped back, and position is the reason why they're not you're not getting chest movement, rather than because there's particulate meconium occluding the airway. Okay. The worry used to be about what if you're pushing meconium into the lungs and cause meconium aspiration syndrome. There is no evidence to support that anymore. So key message again is position, inflation breaths. If that doesn't work, while you're doing your inflation breaths, hopefully somebody's got your laryngoscope and suction ready for you, and then you can have a look and suction under direct vision. Okay, so if there is no chest movement with inflation breaths, then you check your neutral position. The things we used to do before still work. So your 2% jaw thrust, absolutely. That's your go-to method if your initial work doesn't, inflation breaths as a single person jaw thrust don't work. If there is any evidence of particulate stuff like meconium or blood clots or vernix, have a look under direct vision and you can do suction. And then your next option was airway adjuncts. So in the past, your key airway adjunct that was recommended was the Guidel Airways. They are still a good resource to have in your resource trolley and to use where you don't, if there isn't an extra person available for 2% jaw thrust. But there are a few other recommendations with the 2021 guidelines. the NLS finally acknowledges that if there is somebody available at this point who can intubate, you can go ahead and intubate and secure the airway. If there is no one available to intubate, there is other options you can use, or if there is a difficult airway. So laryngeal mask airways have been introduced now. So there are a few options available. So these are the LMAs with an inflatable cuff, and these are the simpler ones, which are the iGels. I have a little video which I can play now showing how you insert these. These are a new introduction. They are away. We've introduced them into our resource trolleys. But having said that, it is incredibly rare that you would have to reach for these. Okay. Personally, and in our experience, the iGels are a lot easier to insert and teach people how to insert them. And there's some recent publications from Uganda, which showed that they are relatively easy to teach and safe to use, even with less experienced operators. So one of the worries we had was about midwives and nursing staff who aren't experienced with using laryngoscopes or inserting airways, adjuncts using these, but the evidence seems to be that they are safe to use. So if I play this video, and hopefully this should work.
This video covers uses and limitations of the laryngeal mask and demonstrates insertion and removal of the device. The laryngeal mask is an alternative airway when mask ventilation and endotracheal intubation are unsuccessful or not feasible. Although laryngeal mask insertion is consistent with the general guidelines for nurses and respiratory care practitioners, check with your state licensing board and your hospital's guidelines for performing this skill. Consider the laryngeal mask when, for whatever reason, you can't ventilate and can't intubate, when resuscitating a newborn with congenital anomalies involving the mouth, lip, tongue, palate, or neck, and when attempting to ventilate a newborn with a small mandible or large tongue, where face mask ventilation and intubation are unsuccessful. Examples include Robin sequence and trisomy 21. The laryngeal mask has limitations. Currently, the smallest size laryngeal mask is intended for use in babies who weigh more than about 2,000 grams. However, many reports describe its use in babies who weigh about 1,500 grams. The device has not been studied for suctioning secretions from the airway. High ventilation pressures may result in air leakage through the seal, resulting in insufficient pressure to ventilate the lungs. Few reports describe the use of a laryngeal mask during chest compressions. However, if necessary, it is reasonable to attempt compressions with a laryngeal mask in place. There is insufficient evidence to recommend using a laryngeal mask to administer intratracheal medications. Consider keeping a few size 1 laryngeal masks where one is immediately available for use, not locked inside a code card or emergency supply box. If the mask is inserted without delay, it may provide effective ventilation in time to help avoid a complex resuscitation. The following segment demonstrates the insertion of a size 1 laryngeal mask. This laryngeal mask has no inflation cuff and no port for an orogastric tube. This newborn of 35 weeks gestation has proven difficult to ventilate. The second intubation attempt has failed. The team decides to insert a laryngeal mask. They have attempted PPV several times, so the baby's stomach may be distended with air. The team quickly inserts an orogastric tube to decompress the stomach. Stand at the baby's head and position the head in sniffing position. Hold the device in your right or left hand as shown, so that during insertion, the hard part of the curved tubing will slide along the hard palate. Gently open the mouth and press the leading tip of the mask against the baby's hard palate on top of the baby's tongue. Maintain pressure against the palate and advance the device inward so that it follows the contour of the mouth and palate until you feel resistance. Attach a CO2 detector and connect the PPV device. After insertion, you should see bilateral chest movement with ventilation and hear equal breath sounds. If this intervention is successful, you should notice an increasing heart rate and oxygen saturation. By the time you've given 8 to 10 breaths, the CO2 detector should turn yellow as it detects exhaled CO2. Now watch as the laryngeal mask is inserted in real time. Secure the laryngeal mask with tape. Monitor the heart rate, oxygen saturation, breathing, and muscle tone. The newborn can cry and make sounds with the laryngeal mask in place. If you decide to remove the laryngeal mask, suction secretions from the mouth and throat, then remove the device. Monitor heart rate, breathing, and oxygen saturation. Now the team will insert a laryngeal mask that does have an inflation cuff. This mask also has a gastric port that allows insertion of an OG tube after the laryngeal mask is in place. The team is ready to insert the laryngeal mask. Quickly inspect the mask and ensure that all the material is intact without tears or kinks. Attach a syringe to the inflation port and completely deflate the cuff surrounding the mask. Maintaining tension, disconnect the syringe. Stand at the baby's head and position the head in sniffing position. Hold the device in your right or left hand as shown so that during insertion, the hard part of the curved tubing will slide along the hard palate. Gently open the mouth and press the leading tip of the mask against the hard palate on top of the tongue. While maintaining pressure against the palate, advance the mask along the contour of the mouth and palate until you feel resistance. Inflate the cuff to achieve a seal. The device may move slightly outward when it's inflated. Assess inflation by feeling the pilot balloon. Never inflate the mask with more than the manufacturer's recommended volume of air. Attach a PPV device and CO2 detector and begin PPV. Assess for chest movement and equal breath sounds. If ventilation is successful, the heart rate and oxygen saturation should increase. By the time you've given 8 to 10 breaths, the CO2 detector should turn yellow as it detects exhaled CO2. Secure the laryngeal mask and monitor the newborn's heart rate, oxygen saturation, breathing, and muscle tone. This laryngeal mask has a port for insertion of an OG tube. Measure to determine the correct depth of the OG tube and insert it down the port. Aspirate the air and stomach contents and leave the tube open as a vent. If you decide to remove the laryngeal mask, suction secretions from the mouth and throat, attach a syringe and deflate the cuff. Then remove the device. Monitor heart rate, breathing, and oxygen saturation.
Okay. Right. So let's go back. Okay. Hope that was helpful. So one of the things is the eye gels do not have a cuff, but the end of it is nice and soft. And basically with the body heat of the baby, it molds around the larynx and actually forms a nice good seal. Whereas with the other LMAs, as you've seen, you have to remember to deflate the cuff before you insert it and before you remove it as well. Okay.
Madhuri, before moving on,
yeah.
Any questions from the team? Have they used eye gels, or is it something you're aware of? Anish?
In a newborn, we have no experience in a newborn for LMA.
Yeah.
But in a grown-up child, we have tried few, but not in a newborn.
Okay.
Perhaps we don't have the
Yeah, but
size.
at least the principles will be the same.
Yeah. It's
It-
exactly the
it's
same
a
principle. So,
smaller size.
Yeah.
Yeah.
Okay.
so I do have a few samples here for show and tell. So the in terms of the laryngeal mask airways, the size ones are probably the best ones for babies. They go for less. It says on the tin that it's less than 5 kilos, but these work for term babies and essentially over 2 kilos at least. So that's what it looks like. I don't know if you can see them. And you deflate this cuff, and on the cuff it actually tells you the volume of the cuff. So this one says it's less than 4 mils. So
By the way, would you
Yes.
just unshare that and show it? Otherwise, you don't come as a big screen.
sorry.
Just unshare your
Okay.
presentation.
Madhuri, which case, finish your presentation.
Yeah,
I'll finish my
and show it,
presentation
yeah.
and then
Then
do
we'll
the
go through
demo.
the IGEL. Yeah. Because the other difference I want to make sure, when we use the oropharyngeal airways, the Guttle's airway, we expect it to be flushed with the lips.
Mm.
So that's not the case with the IGEL. IGEL will stand proud.
Yeah.
Yeah. So
Yeah.
we're not expecting it to go all the way in.
Yeah.
Does Nipun know whether they have been using it at all in Sydney Memorial?
We do have that, but we have never used it.
Right.
Yeah, that's the
Uh,
point.
We were just saying this, Nipun. For the last few courses we taught, none of the instructors had used it in a newborn baby either. So you're not alone.
That's the whole point is it's there as a helpful adjunct.
Yes.
But what NLS is moving towards is if there is a skilled person to intubate, you intubate.
Yeah.
So that gives you a secure airway.
Actually, it's not available in Nepal. Actually,
Pardon?
it's not available. Actually,
Yes.
it's not.
Yeah.
That's true.
That might be
It's a
instead
new,
of we
new
use
tool.
Goodles. Yeah, Goodles we use it during resuscitation, and it's not available, and it's not very good to train also it.
If it's not available, there's not much point, and they are expensive. So they have not removed Guttle's airways from the manual. So particularly for preterm babies, then the sizes of LMS that are available are not. There are no commercially available sizes that go for less than 2 kilo babies.
Right.
At a push, you can get an iGel into a 1.5 kilo baby, but a Guttle's airway is perfectly usable in those situations. And as John said, if you can intubate, go ahead and intubate. And I think we're still emphasizing teaching people how to do a proper 2% jaw thrust and manage the airway that way. And that is still the go-to first option if your initial 5 inflation breaths don't work. Okay.
Yeah.
Right. So moving on, breathing and circulation. So in terms of breathing, so you've got your 5 inflation breaths, you've seen chest movement. So at this point, if your heart rate is still slow, you give 30 seconds of ventilation breaths before commencing chest compressions. By this point, ideally, you should have a SATS monitor on the baby and have some saturations available, and you can titrate oxygen according to the SATS. If you are using a TPs, this is a good place to think about, are you giving some PEEP where available, and it's recommended at 5 to 6 centimeters as a good starting point for PEEP. You've done your 5 inflation breaths, you've given 30 seconds of ventilation breaths, you've got good chest movement, but your heart rate is still less than 60. And this is a good point to start chest compressions. The ratio for chest compressions is 3:1, so 3 compressions to 1 breath. You do it for 30 seconds and reassess. And at the point of starting chest compressions, if you haven't titrated your oxygen up, crank it up to 100%. Okay. So you've gone through A, B, C, and unfortunately you've gone down to D. This baby's in a lot of trouble. So we teach on the NLS how to insert an umbilical venous catheter, but as we know, that might not always be successful, and occasionally it might not be possible. And in those cases, we can consider an intraosseous needle. Again, personally, I've not had to use an intraosseous needle in delivery suite, but on the neonatal unit, we have had babies that we've had to resuscitate with an IO because UVC was not possible to insert, particularly with an older baby that's collapsed on the unit. So they do work, and they are a good one to remember that, and that they exist. In terms of drug doses, the big change is the adrenaline dose, whereas the old manual used to suggest 10 to 30 micrograms per kilo, or 0.1 to 0.3 mils per kilo, 1 in 10,000. They've standardized it to 20 micrograms per kilo of adrenaline for the first dose and for all subsequent doses. Just to make it simpler, there is absolutely no evidence to say one is better than the other, but at least it reduces the confusion during a resuscitation scenario. You can give this as intravenous through the umbilical venous catheter or intraosseously, and you repeat it every 3 to 5 minutes. You can give intratracheal adrenaline as well at 1 ml per kilo. So that's 100 micrograms per kilo of 1 in 10,000. Other drugs you can give include volume with 10 mils per kilo, dextrose, 2.5 mils per kilo of 10% dextrose, and bicarb has moved slightly down the list in terms of preference. So routine use is not recommended, mainly because there's not much evidence. But if you've got a prolonged resuscitation, there is some evidence from lab studies that adrenaline doesn't work very well in quite an acidic environment. So giving 1 to 2 millimoles per kilo of sodium bicarbonate, which will be 2 to 4 mils per kilo or 4.2% bicarb, would hopefully help the adrenaline to work a bit better. So our practice is basically give your first dose of adrenaline, and then if it's prolonged and you're getting to your second or third dose, then consider giving some bicarb. I have copied this from the manual. So this is what the drug doses looks like now. On our unit, we have basically printed this out and laminated it and stuck it on our resus trolleys. One of the things I like about this is for term babies, they have done an estimated weight calculation of doses and got that up there. So when you're teaching, and also in a research situation, it's much quicker for the nurses to draw up the medications at the standard doses. Okay. Unfortunately, as we know, not all babies respond to this. A small minority of babies might not respond despite us doing everything right. So if your heart rate is, if there is no heart rate at birth and the heart rate is still absent at 10 minutes after good quality resuscitation, then the prognosis doesn't look very good. So this is a point where if you haven't done it already, we should reassess and see if you've ruled out all the reversible factors, and to make sure that your airway is still patent, you've still got good chest movement, your chest compressions are still effective. And think about any reversible factors. Is there any pneumothorax that is there a tension pneumothorax that's impeding the chest movement? Is there was there blood loss? Does the baby need? Was there a fetal-maternal hemorrhage? Does the baby need O negative emergency O neg blood? So think about reversible factors at this point, and also consider the overall clinical picture as well. And for babies that don't respond, and ideally this shouldn't be a single person making this call, it is a team discussion. And if you've done good quality resuscitation, you've ruled out all the reversible problems, and there has been no response after 20 minutes, then stopping resuscitation should be considered. Okay. So in summary, so you start off with drawing, covering the baby. You assess the situation, so color, tone, breathing, and heart rate, and you do this while the baby is still attached to the placenta. Think about, do you need help? So you're considering umbilical cord management, so delayed cord clamping is preferred, but cord milking where that's not possible for late preterms and term babies. You manage the airway, so neutral position, inflation breaths. If the chest doesn't move, think about airway adjuncts. So that's still 2% jaw thrust, suction under direct vision, or either a Guidall airway or intubation or laryngeal mask airways. Then inflation breaths, then 30 seconds of ventilation breaths. Reassess if the heart rate is still slow, go into circulation. That's chest compressions, 3:1 ratio with 100% oxygen at this stage. And then consider drugs, that is through a UVC or intraosseous needle, with start with adrenaline at 20 mics per kilo. So that, in a sense, is the summary. So welcome for any questions. I will stop sharing. Back to you.
Thank you very much, Madhavi. That's excellent presentation. Yeah. So